Good afternoon everyone. I am Dr. Sakshi Yadav, Assistant Professor of Hypertensive Emergency Medicine at SMCH. Today we will discuss hypertensive emergencies. So first of all, what is a hypertensive emergency? It is an acute elevation of blood pressure that is more than 180 by 120 millimeters of mercury associated with end organ damage, basically on kidneys, brain, heart, aortas and eye. Now, other than hypertensive emergency, we have another entity known as hypertensive urgency, which is just a clinical presentation associated with elevation of blood pressure but not associated with end organ damage. So, now the basic hypertensive emergencies which we deal in a common emergency department setting is stroke, acute coronary syndrome. Retina, we have hypertensive retinopathy. On vascular diseases, we have acute aortic dissection. In pregnant patients, we have eclampsia, preeclampsia. So we will go to each and every topic one by one, and we'll discuss the blood pressure control. How much blood pressure should be controlled in each and every hypertensive emergency cases. So starting from the top, that is starting from the brain. On brain we have different effects, like first of all we can have stroke, which can be intracerebral hemorrhage along with acute ischemic stroke. We can have hypertensive encephalopathy, we can have AIA, and we can have in intracerebral hemorrhages we can have subarachnoid hemorrhage, we can have EDH or STH. Then on brain, other than brain, on heart we can have acute pulmonary edema, acute congestive heart failure, acute coronary syndrome, blood vessels, acute aortic dissections, and microangiopathic hemolytic anemia. In kidney we can have AKI, retina, papilledema, hemorrhages and retinal edema, and then as previously said in gynae we have eclampsia. So starting from neurological symptoms and severe hypertension. Elevated blood pressure associated with sudden onset of headache, neurological deficit or altered mental status. In case of subarachnoid hemorrhage, our therapeutic goal is to maintain BP of less than 160 millimeters of mercury in order to prevent further bleeding. Avoid hypertension. BP parameters have not defined yet. In case of subarachnoid hemorrhage, the recommended agent for blood pressure control are nicardipine, labetalol, esmolol and clofazimine. Nimodipine can be used in case where we are suspecting vasospasm. In case of ICH for BP control, there was a study known as INTERACT trial, that is intensive blood pressure reduction in acute cerebral hemorrhage trial. As per this trial, BP of more than 200 millimeters of mercury or MAP of more than 150 millimeters of mercury consider aggressive BP management with continuous IV infusion of medications. In case of BP more than systolic blood pressure of more than 180 millimeters of mercury or MAP of more than 130 millimeters of mercury with signs of raised ICP like headache, nausea, vomiting. In that case, consider monitoring ICP and reducing blood sugar intermittent or on continuous IV medication infusion to keep cerebral perfusion pressure of more than 60 to 80 millimeters of mercury. Make sure the cerebral perfusion pressure should not reduce less than 60 to 80 millimeters of mercury. In case of BP more than 180 millimeters of mercury or MAP of more than 130 millimeters of mercury, but there are no signs of raised ICP, in such cases we can consider a modest reduction of blood pressure, that is MAP of around 110 millimeters of mercury or target blood pressure of 160 by 90 millimeters of mercury with either intermittent or continuous IV medication. Now, in case of patients with acute ischemic stroke, first of all we have to consider whether the patient qualifies for IV thrombolysis therapy or not, which means whether the patient presents within the window period or patients are having any contraindication for thrombolysis or not. We have to rule out first of all contraindication for thrombolysis if the patient is within window period, that is 4.5 hours. In such cases, if the patient's BP is on higher side, that is more than 180 by 120, in that case, if the patient is a candidate for thrombolysis, we have to maintain a BP of 185. We have to maintain BP less than 185 of systolic blood pressure, and systolic blood pressure should be less than 110 before initiation of thrombolysis. And after thrombolysis, the BP should be less than, systolic BP should be less than 180 and diastolic BP should be less than 105 for first 24 hours. In case our patient is not a candidate for thrombolysis and his or her BP is more than 220 systolic and 110 diastolic, in that case the blood pressure should be reduced by 15% over 24 hours over a day. It should not be reduced aggressively within hour or within few hours, because it will decrease the cerebral perfusion pressure, which will further lead to adverse effect. In case BP is less than 220 by 110, in that case, initiate the hypertension treatment within 48 to 70, first 48 to 72 hours in order to prevent death or dependency. For pre-existing hypertension, in case the patient is already a known case of hypertension, re-initiate antihypertensive drugs after neurological stability. We are not supposed to reduce BP aggressively in case of acute ischemic stroke, whereas in contrast to acute ischemic stroke, in case of intracerebral hemorrhage, in case the patient presents within 6 hours of symptom onset and BP is more than 220 millimeters of mercury, we are supposed to decrease the BP aggressively with on IV infusion medications. In case the BP is between 150 to 220 millimeters of mercury, consider reducing BP to less than 140 millimeters of mercury. Now, the agents used both in ischemic stroke as well as hemorrhagic stroke, we can use labetalol, nicardipine and esmolol. Early hemorrhage growth often occurs within the first 6 hours, so we have to be vigilant. We have to reduce BP in first 6 hours. Aggressive BP control diminishes the hematoma growth, morbidity and finally mortality. Now, next emergency is hypertensive encephalopathy, where a patient presents with altered sensorium and a raised BP. In such case, the therapeutic goal is to decrease the MAP by 20 to 25% in the first hour of presentation. Here, we have to reduce BP because the symptoms are only due to raised BP. So we have to eliminate the cause. So decrease MAP by 20 to 25% in first hour of presentation. More aggressive lowering may lead to ischemic infarct. So we have to be vigilant for that also. The agents used are again nicardipine, labetalol, clopidogrel and phenolphthalein. Now coming to heart. In case of chest pain and severe hypertension, first of all we have to, in case of any patient presenting with chest pain and high BP, we have to look for blood pressure in all 4 limbs in order to rule out acute aortic dissection. In case of acute aortic dissection, the patient will present with abrupt onset chest pain, tearing type chest pain, which will radiate to back, and it is usually defined as tearing or ripping and relating to interscapular lesion. On physical examination, 31% will have pulse deficit, 28% will have diastolic murmur, and 17% will have neurological deficits. In case of acute aortic dissection, the relevant investigations which are done are ECGs, D-dimer, C-reactive protein and CT chest. So our main target here is to reduce BP, systolic blood pressure to less than 120 millimeters of mercury and heart rate should be less than 60 per minute. The most common agent which is used for such purpose is labetalol. Other than labetalol, we can use esmolol, nicardipine and nitroprusside, and pain should be controlled with opioids. In case of patient presenting with high blood pressure and acute myocardial ischemia, the agents used for reducing BP can be nitroglycerin. Avoid using nitroglycerin in case of inferior wall MI along with right wall MI. And other than nitroglycerin, we can use metoprolol or labetalol infusions. The agent which should not be used are hydrolysine and nitroprusside. Now, other than acute myocardial ischemia, the next hypertensive emergency is acute renal failure. In patient with new onset renal failure, patient may have peripheral edema, oliguria, loss of appetite, orthostatic changes, nausea, vomiting, and confusion. The lab parameters which can be used are elevated serum creatinine and abnormal urine sediment. The agent recommended for acute renal failure treatment are phenoldiazepam, labetalol, nintedanib, and clopidogrel. Phenoldiazepam improves natriuresis and creatinine clearance. The goal is to reduce BP by not more than 20% acutely. The next hypertensive emergency is eclampsia and preeclampsia. For mild preeclampsia, systolic blood pressure should be more than 140 millimeters of mercury and diastolic more than 90. Along with that, protein of more than 0.3 gram in a 24-hour production and more than 20 weeks of gestation, with no other systemic signs or symptoms. The goal is to reduce BP less than 140 millimeters of mercury during the first hour, and the agents used are labetalol 20 mg IV, then 40 to 80 mg IV every 10 minutes as needed. Next is hypertension, which is an anti-vasodilator, and its dose is 5 mg IV. Next, we can also use nintedanib, which is a calcium channel antagonist. Duration of action is 10 to 20 minutes. Dose is 10 mg per day. Next hypertensive emergency is sympathetic crisis in severe hypertension. Signs and symptoms of pseudocytoma can be found in such patients, that is headache, tachycardia, alternating periods of normal and elevated BP, fresh skin. Recommended agent is phentolamine, bolus load of 1 to 5 mg IV, and continuous infusion of 0.2 to 5 mg per day. In case of sympathetic crashing acute pulmonary edema, which is defined as abrupt onset of shortness of breath with progresses over minutes to hours into life-threatening pulmonary edema. Patient may present with severe respiratory distress, restlessness, diaphoresis, hypoxic tachycardia, and marked hypertension. In such cases, NIV and NTG are the mainstay of treatment. Bolus NTG can up to 500 to 1000 hikes can be given every 2 minutes followed by NTG infusion. Next is hypertensive urgency. In hypertensive urgency, for BP more than 180 or 110, consider initiating therapy at discharge from emergency and follow up within 1 week. Such patients can be managed on oral antihypertensives such as calcium channel blockers. In case of patients with BP of less than 180 and more than 160, advice follow up within 1 month. And hypertensive emergency should be admitted under respective department. The take-home message from this lecture is don't treat the number, treat the patient, look for end organ damage. Mark should not be reduced to more than 25% over first hour. Thank you.